So recently I had the chance to talk to a good friend of mine, Ian Linane, at the College of Podiatry Conference down in Bournemouth. Now, I was trying to catch up with him earlier in the year, an event we did in July on a training course he was running, but unfortunately the audio didn't match the video, so it wasn't good. So I've been dying to get hold of him again, to ask him a few questions, find out a little bit more about him and about what he's doing in podiatry, and the following interview is the result. So, enjoy. Right, okay. So we are at the. We can look at the camera. We can look at me. It's fine. It's all good. So we're at the College of Podiatry Conference, and actually we're up on the balcony. The College of Podiatry Conference 2018, which is in Bournemouth at the Bournemouth International Centre, and I have grabbed Ian Linane to have a quick chat with. And we had a bit of a chat back in July, didn't we, on the fascia course? But I messed the sound up, so we're doing something a little bit different with proper sound this time. So hopefully the sound and audio will be brilliant and the video will match up and it will be great. But I wanted to catch up with you just to find out a little bit more about you. Excuse me, because you're like podiatric royalty as far as I'm concerned. We first met, it's almost a decade I think we met. And we first met it was at a conference. Yeah. And it was a conference and it possibly was Harrogate.
Must be.
I think it was Harrogate.
Yeah, rings a bell.
Was it Harrogate? I think it was Harrogate 2007 when we were talking about, and you were just talking about the genesis of your foot mobilisation courses, and then we kept in contact. So we've known each other a little while now, and it's been brilliant. But a couple of questions. I've got a load written down here on branded paper, which hopefully you can't see on the video.
I can't see them anyway because I haven't got my glasses on.
Yeah, who said that? So here's a question for you. Where does Ian Linane come from? What's the story of Ian Linane?
Multiple different job experiences, from snow fencing on the Pennines in my youth when I had muscles, working in the weaving industry in the cotton mills in Lancashire. I was a vicar I was a Baptist minister for about 10, 11 years. Then I came into podiatry, and then through podiatry I've just explored different areas, and I think I've never explored anything particularly deliberately in podiatry. I've kind of like fallen into it. Probably the exception that when I've gone really deliberately was my initial interest in the fascial stuff. But I mean, that's a slightly different story, but that's probably the one thing in podiatry I've actually deliberately got into. The manual therapy stuff I drifted into, but then I began to kind of own something of the desire to explore and understand it. and I mean, I said to you just a few minutes ago, I'm still learning. The foot mobs has been, as material, written material has been rewritten now at least 3 times, and I've started to rewrite again into the introduction bits because I want to bring in pain science. I want to bring in use of metaphors, language, the psychosocial element into it because that's crucial. And I did think I knew just recently. I was thinking, that's how this particular thing works. But I had a conversation with someone yesterday who may make me rethink. So it's always been a journey. Life's been a continual unfolding, learning, evolving journey, and it still is.
So why podiatry? What got you into podiatry, and what's that chunk of your story?
Dead simple. Unemployed, wife, kids, need money. All right, simple as that. And I trained originally through the Smay Institute with the correspondence course stuff, and turned up and did my practical bits, and then just added on through their modular learning from that point. I'm going to say that if I compare probably what I learned back then to what they're learning now, I suspect they're learning more and better now than what I learned back then. So yeah, that's where it all started, and then started with a kind of like domiciliary, building it up from there, and then just gradually started to try and build it up. But from there, after I'd done the biomechanics stuff with them, I actually was reasonably convinced that I could help physiotherapists do reasonably well by doing their biomechanics, and then went and worked with a really, really good physio who, and I did tell her this after knowing her for over 22 years, I said to her recently, "You're the person that inspired me to become involved. I said, because what it was is I watched the way you moved into a patient space. This comes back to the biopsychosocial stuff, doesn't it? You moved into the patient space with an understanding and an insight into what you wanted to do. And I suddenly realised that you guys, who I thought I could help with my biomechanics, you were teaching me loads. And that's where it kind of progressed. That's where I got involved in the rehab stuff.
Can you name that person who inspired you?
Yeah, I can. A lady called Moira Darcy.
Okay.
And you know, she's an incredibly good friend anyway. But that's the person that kind of, without her realising it, let me watch her work. Nudged me along and made me kind of just think, yeah, I want some of that.
Yeah, because even now we're still talking.
Yeah.
There's been lectures over the last 3 days talking about multidisciplinary working, and ultimately that's what you were doing. It was multidisciplinary working before I suppose it even truly existed as a term.
Yeah.
It's always been around.
It has, and you know me. Of course, I'm part of the Woo camp, as you understand. That,
The Woo camp.
And
we should have that on a T-shirt.
we should have that on a T-shirt instead of I love over pronation. It's I love Woo. And
I'm going to write that down.
Write that down.
I love I heart Woo. There you
yeah.
go.
So from that point of view, I ended up working in a complementary medicine clinic, and I got involved in kind of some weird and wonderful kind of approaches and reasonings, and you know, I trained in 5 different styles of reflexology. I did thought field therapy, which was the use of acupuncture points in relationship to emotional distress. I did all kinds of stuff. So multidisciplinary, multimodal thinking in terms of approaching it from different clinical reasoning aspects, whole body, holistic mindset has been there really for me from the outset. I think the other thing as well is conversations I've had recently where people have been talking about the research and more qualitative research being more valued now, and the idea that we're talking about that human experience of health and wellness and recovery and how we need to get into that. I said to someone the other day, I said, I really struggle, because why is that new? You know, what is it? There's nothing new. It's what's been done for donkey's years, what we've all known we need. But it seems as though somehow now, because I'm not a researcher, so I could be careful what I say, but it seems somehow now we've been down that quantitative route long enough and got information to realise actually that's not the answer per se, but there's some powerful qualitative elements going on in the human experience of health that we need to start to take on board and use a quantitative maybe to feed into that. So it'd be interesting to see if that in the end turns around. I don't know what I'm talking about because I'm not a researcher. So Emma Cowley and Jill Helstad would be going, oh God, we're going like that to me.
I'm sure there won't be. But it's really interesting because, you know, when I watch you work and I watch you teach and on the courses, and I'm sure other people get this as well, you approach it in a way which is almost magical. I know, okay, you laugh at that, but you look at it and you approach the patients, and every time you approach it's a different approach, and that may be down to all of these things that you've done, where you've got a really good way, and all your experience, even before podiatry, all your experience of working with people and reading people and knowing what to do with people, you can approach them and go, right, this is the technique I'm going to use to start off with, and I'm going to step back and see what it does. And then I'm going to try something else, and then I'm going to use my language to support what I'm doing, or my questions will bring out certain things I'm looking for. And it is really magical to watch.
Right.
I mean, we maybe need to get you a magic hat as well. But the skills which you've got are learnt over a long period of time. How would you be able to get those kind of skills, not to your experience, but how would you actually start getting those skills in maybe undergraduate learning? Is there something which could be added to undergraduate learning to help with that?
I'm not an educator in that context, so
you do courses.
No,
but
in the uni context, and I think they have got massive constraints in terms of what they've got to achieve academically, clinically. So I think therein lies part of the nub, which is its interaction with individual patients in conversational level with them and understanding their human experience of their condition, what it means, how it feels, how it's changed them. That probably begins to feed into you as an individual. But I don't know how you can create that space within the educational context that's so constrained. Who knows? As education changes 10 years from now, maybe that will be an important part of it. I think the fact that we're now talking more about psychosocial may give it more weight and more emphasis within that learning experience for students. But I'm not an educator, so but I'm very conscious of their time constraints. But somebody said to me recently, "I'd love to be in and watch you work," but they said, "I know that if I did, it would change you because you wouldn't work like you normally work." And I said, "Yeah, I would probably be shitting brakes actually, if you came and watched me." and I probably would. But it does change it. But the same conversation I was saying, what you could also be asking is, do people get better with what I do because of what I say and how I listen rather than actually what I do?
Yeah.
And that comes back to the whole manual therapy, the whole area of rehab as well, which is we're still trying to work out what is really going on. But there's no magic bullet. There's no one thing, anything you can do.
No, absolutely. And I think your point about education, the curriculum is massively full, and
you've done it anyway.
Absolutely. I mean, the undergraduate curriculum is massively full. There is so much going on with it already. Putting anything else in there is going to be. And you mentioned Emma and Jill, and Emma in particular. If I said to Emma, "This needs to be in the curriculum," first of all, she'd shout at me.
Yeah.
But secondly, it's where do you fit it in, and if you put that in, what do you take out? So maybe the step here to go into the biopsychosocial stuff and actually starting to look at the more sort of humanistic approach is actually in the people who are already practicing. Those are the people we focus on because that's the experience then they give to the students when they come out on placement, and they can translate that for them. Maybe that's an option.
It is, but also, again, the caveat is I don't understand education, so as it's done, I think they've got a damned hard job. But if we move our podiatry training into a more apprenticeship-based role as well, then apprenticeship is where you learn some of those skills because you've got the time, theoretically. You've got the time and the environment. You've got the environment to get something not quite right, as long as it's not at a massive risk to the patient. You've got the environment to acknowledge a mistake and acknowledge a lack of understanding. It's really quite interesting because I've got grandkids, and my youngest one is 2.5. She has learned to say, "I need help." So if she can't do something, she will do her best, but she'll say, "I need help," at the age of 2.5. And it's a really interesting concept. And yeah, as an adult, isn't that the hardest thing that we
absolutely.
As though moving into adulthood means that I don't need help anymore. I think it's maybe that apprenticeship role provides an environment for learning those human components to our approach.
Yeah.
Will be easier than trying to do it in the context of what's like a hothoused educational process. And I know some of the educationalists who want to see those students get that chance, but they are constrained by what has to happen.
Yeah, absolutely. They're limited with the placements available. Yeah, absolutely. I've done that question. I'm not sure that question kind of went somewhere, didn't it? So, fascia.
Okay.
Fascia is kind of your thing now, isn't it? Fascia's been the big change for you in recent years, and
okay.
I remember when we first started talking about the joint mobilisation courses, and there was almost a point about 2010 where joint mobilisation courses and manipulation courses became fashionable.
Yeah.
There was a few people came out, kind of appeared and said, right, let's start teaching this stuff. It became fashionable, and it was great. It was another treatment option, another way of helping patients and serving patients. But then fascia came along. So tell me about when fascia came along for you. What was the big turning point for you?
Context. Fascia is not new. It's been around for yonks, and the physios, the osteos. I mean, connective tissue work is certainly a fundamental part of osteopathy. So what we're doing as I'm talking about fascia is I'm kind of borrowing from the osteos and the physios and thinking processes. I'm still at the very beginning of the learning curve about the anatomy of it. I'm at the very beginning of the learning curve about the history of it, and very definitely at the beginning of the learning curve in terms of the practice. I think we have to recognise that over the last 40 years, people have made claims about what you can do with fascia, how amazing you can make some changes, that you can change fascial tissue by some deep rubbing on it. We now know pretty much that is nonsensical to the actual tissue. It's not designed to be bashed about and pulled about and massively altered by a rubbing of it and stretching of it, because in a lot of cases it doesn't stretch anyway. So where I think we've got to change is a better understanding if we're working with fascia, and this is coming back to the Stecco model that I use, and it's just another model, is that maybe when we're working with fascia, we're working with aspects of its constituent parts rather than anything of the fibrous tissue itself. And that seems to make a bit of sense, because we can maybe do something with the constituent parts. That would be some of the chemical level stuff, and the Stecco model works on the basis of working on hyaluronic acid and the changes that go on there. I haven't worked with the physios and watched them do anatomy trains and fascial slips and slings and everything else like that. It was way above my head, and I could never really understand how I could apply that in podiatry, because it's definitely, you know, this transference, this continuity all the way through the body, and it is with the Stecco model. But I'd read loads of papers by Carlo Stecco, Antonio Stecco, unrelated to the training course, because I didn't know they ran training courses. So it fascinated me as the tissue. Then I inadvertently found out there was a course running in London, and on the week I found out about it, I had a massive wrestling problem. I rang up the guy who was running it 3 times in that week, and each time he told me there's an exam at the end, and I just said I'm not interested. All right, I just don't want to know, because I said I'd never do another exam. And then on the Friday, I think it was the day before it was due to start, I rang him up again and I said, is there still an exam at the end, as if to change it for me, you know. And he said, yeah. I said, well, I can't tell you what I said, but I thought, I've got to do this. I said, it's just doing my head in, I don't know what it is. And I went on that and found myself working whole body fascial approach, Stecco method approach, and was like a rabbit in headlights. I just didn't know where I was going. I was completely out of my depth, and just struggled so much in that learning curve. And I'm going back to do levels 1 and levels 2 again in January to March next year, because I have stuff I've got to get my head around more. So I'm repeating the courses because I need to understand more. So I got into fascia that way around, and I allowed myself to become geeky. Everything is fascia, you know, the universe is fascia, and I've allowed myself to come out that side. So that I've enjoyed that moment, I've learned from it, and I'm now able to come with a more broader perspective. But I think you have to go through that moment. You have to allow yourself to go through that. Otherwise you don't actually really take it on board.
It is a big change though, isn't it? Fascia is a big shift, and when I did it in July, and we had conversations about this, and it just blew my mind. And I've done a reasonable amount of education, you know, in podiatry over the years. Exactly, yeah. You know, I had a full head of hair when I started podiatry. Yeah. But I have to say that the 4 days on the fascia course were probably some of the toughest days I've had, because you are presented with something which is so different to what you've done before, but seems to have such good results, which helps to move you on. Yeah. And then you know there's kind of success the other side, but it is a real hard course to do. You have to unlearn so much almost to start learning again. Yeah. The exam's kind of a minor thing. Yeah. The exam's a minor thing, but still it's there at the end, and there's that extra pressure to do it. I found it particularly hard. And even now, it's stuff I don't get my head around, and it will take time. So, you know, I'm well impressed you're going back to do it again, but the results you're getting from it are amazing.
Yeah. You know what I'm going to do, don't you? I'm going to qualify that, aren't I? And I'm going to say, in the ones I follow up and I'm able to follow up, there's been a consistently improved state. There's a few people where there's been regression, but I can count them on the one hand.
Yep.
And one of those was very definitely a multiple flag issue, and I think came my way for whatever reason. And but it didn't mean that they couldn't be approached that way, but you just had to be aware that there's big psychosocial things going on. That was probably the biggest driver for them. So yeah, I think the way to look at the fascia thing is British Journal of Sports Medicine published a big review on fascia, and you've got leading fascial researchers, leading researchers that aren't necessarily involved in fascia per se, kind of bouncing these ideas around. And their conclusion was, actually we need to take notice of this, but we're still a long way from really understanding it. So let's not make it bigger than what it is. Mm-hmm. However, let's also start to really work with this so that we can really start to understand how it might work. So I take my view is, I think we're pretty strong and can say, this is fascial tissue, this is hyaluronic acid, this is neural tissue inside fascia, that we can say, yes, there's good reason anatomically why there might be force transmission. And you might then come up with a model of how you might work with the fascial tissue to do pain relief or help limitations of movement. The closer that model sits to the anatomy, the better. The more you move the anatomy, the closer that physiological model sits to the anatomy, the more certain you can be that you'll be honouring that. The more it moves away from that anatomy, the more you're in danger of making claims for something that we really cannot demonstrate. So that's my caveat and all of that. So having said that, I still get myself completely surprised by the outcomes and the results. And interesting papers recently have been showing that when they've done reviews, for some people what they're saying is it reduces the number of treatment sessions that people might need by at least 2. Now, economically, in a hospital context, for pain management, that could be helpful. But we've still got more research to do as to how to work with it. But I think the other thing is coming back to the patellofemoral pain lecture yesterday, where the patellofemoral issue was arrived at by a diagnosis of exclusion. It's not this, it's not that, it's not this, it's got to be this. And we've had lectures on bone modelling, on mechanical structures, the whole range of things, and we've taught ligaments, we've taught muscles, but the one tissue we've not spoken about at all, with the exception of Chris Nestor mentioning the word fascia within his lecture as part of the living structure of the definition of biomechanics, is the connective tissue system. And I suspect that if we're going down that model of biomechanics that Chris was referring to, then fascia may actually have to have a bigger part in our thinking processes. So for me, it's helped my patients enormously. It's helped me to get them out of pain so they can move on to their functional rehab much better, feeling as though they can engage their muscles better, feeling as though they can actually utilise that strength. The strength already exists in the muscle for them, because it's instantly being restored once you've solved the fascial component side of that. So looking at it in that context, it's healthy. To look at it as it solves everything is to be so far away from the anatomical information we have, is to be a bit worrying. But I think there are some good and right critics about fascia that says, I think it takes 460 newtons to extend fascia by 1%. I mean, there's no way I can break fascia down with one finger by rubbing it. So, there's all kinds of stuff we've got to be aware of.
So fascia has a future?
I think it has a future role in rehab, and I think it's probably got more of a bigger role in rehab than what we have. But we have to move away from thinking about the kind of fibrous side of it and thinking more about what's the components that we can actually make a change on. So the Stecco method takes the view of trying to address changes that have gone on within the hyaluronic acid, which causes the hyaluronic acid to become increasingly dense, and that by working on that substance through a friction, you actually initiate some inflammatory reaction that allows that density to revert, but then also continue to go through its reverting process for 48, 72 hours, and that's what seems to be the winner. They've got some good research demonstrating that kind of area. So, that's the bits I think we can work with. And but you know, I'm not an authority. I'm not at all. You know.
So you've got courses going on this year. So yeah, part of the future for fascia is, from a podiatric perspective, is you educating people on it.
Helping facilitate it. Yeah.
Yeah.
I mean, for me to teach the fascia stuff, there's quite a lengthy training progress. I'm 61. You know. I mean, I can be about 93 by the time I finish it. But there is a
2 by 62, you'll be fine.
It's my job to facilitate the option for podiatry to do it, and to be involved in working with who will be the people who are going to teach it, and to get that door open for podiatry. I mean, in all fairness to the Stecos, when we put a pilot course on, you know, the question is, you know, fascia is a continuity. So can we actually cut it off at the pelvis and still use it? And I think what I was able to demonstrate from my own work over 2 years is that actually in a lot of cases, yes, I can. There are some people where I've had to go upper body, because I'm training in the upper body side of it.
Yeah.
There are some people where I've had to go up into the upper body, but from the podiatric perspective, it's been few and far between. So when the Steco and Antonio came and did the pilot course, you know, their worry was that we would be disadvantaged by not being able to do whole body stuff. That was their worry. It wasn't, no, you can't do it, it's that we don't want you to lose out. And what Antonio felt from the conversations with everybody in the room, you know, it was a good bunch of people, was actually it's a modality that could advantageous us and could be really beneficial. And for that reason, they kind of said, yeah, let's do a podiatry specific course from the pelvis down, and that fits within our remit.
Yeah.
So yeah, my job is to facilitate the courses, and you know, we were talking earlier on about how you and I were talking about things that impact us and impact our training, and I've said to you that I'm rewriting my courses, I'm rethinking, and fascia has impacted me in my clinical reasoning in lots of ways. So here's an example of why. I still undertake and do soft tissue work, soft tissue massage, and I use it and I employ that, but next year there are no soft tissue courses.
That's interesting, okay.
Because what I would like to do, if possible, is to take one or two components of the soft tissue course and build them into a protocol within an ankle mobs course or within a foot mobs course. I could still do 2 days of teaching soft tissue work, and that could be really valuable and helpful, and I've no objections if somebody wants me to do that. But I think the fascia approach for me has significantly changed enough and impacted my practice enough to say, you know what, I think we need to push this in a different direction, and I will try and take some of the soft tissue stuff and build it into those other courses a little bit. But the bigger value, I think, to the profession is going to be being able to work, possibly learn to work with fascia, incorporating it into the other modalities that we use.
Cool. Okay, let's change tack slightly.
Right,
Only very slightly, because you touched on a couple of things. With podiatry, we're in a bit of a weird place. There's lots and lots of change going on.
Right.
And there's probably two questions in here which you can answer, and they may come together. The first one is, where do you see podiatry in 5 years' time? That's the first question, so hold that one in your head. The second one is that is around the fact that podiatry is changing and needs to change and will have to change in order to, I suppose, survive is probably the word I can think of. It's the first word, because we are at risk. We discussed that earlier this morning. Now, the term I keep using is the foot health revolution. That's the term which sits in my head. And it might sound a bit kind of revolution, but I actually think that the foot health revolution is probably something which we need to do. We need to have a massive change. So, two questions are, where do you see podiatry in 5 years' time? And what does the term, the foot health revolution, mean to you? What kind of thoughts does it conjure up for you?
The first question, I'm not politically astute in terms of where podiatry will be in 5 years' time. I don't mean just politics, but I mean in terms of all the machinations. I don't envy anybody who are in the big decision-making processes. I've done big decision-making processes in large groups in the past, and I don't envy them, because everybody will find good cause to criticise until they actually start making the decisions themselves, and then they realise it's not quite what I thought. So, that having been said, I think one thing I wouldn't like to see it as is in the same place, asking the same question, trying to still struggle with a sense of identity that it does now. If we're there in 5 years' time, we kind of justifiably deserve to be got rid of. Because if we can't, as a collective, own something, build on something and move it on as a collective within that next 5 years, however much it might move on, then we're wasting our lives, and we're wasting the lives of those who are trying to train up in it. So I would like to see in 5 years' time that we have at least really begun to own our identity as providers of expert low limb healthcare, with a consequent or subsequent knock on to the rest of the body. I think that's what I would like to see us doing. Whether that's the diabetes, whether it's rheumatology, whether it's fascia, whether it's mold, whatever it's and the rehab. I would like to think that in 5 years' time we've begun to have something that we own that says, this is who we are. This is what we do. And you know me, I struggle. Anyway,
I struggle.
I just struggle to own anything. But I think if as a profession we can in 5 years' time reach that point, then I think we're in a good position to move on into the next 5 years and make a real even bigger change. What was the second part?
About what does the term foot health revolution mean to you?
Right, so when you asked me that question, I thought about that term, and I thought, what we shouldn't be as a group is defined by our name. We shouldn't be defined by the name chiropody, we shouldn't be defined by the name podiatry, because if we're defined by that, it could potentially become constrictive and constraining in our capacity to expand and evolve, because you're a podiatrist, podiatrists do this. So I think it's interesting to think whether or not, 5-10 years from now, the name podiatry is replaced. That would be interesting, wouldn't it? Because we've evolved, we've changed. So the core element is podiatry, because that we're focusing on the foot and the ankle and the low limb, and that's a part of our identity. But the name that you've given there could still involve, that's what we are as podiatrists. But this is the bigger picture, and I think over the years I've got older and older and older, which is obviously fairly logical.
Which happens,
I'm conscious of how much we do allow names and titles to define us, and I think we need to sit loosely with all of those things, so that we're not held back by them, but they give us an identity, but an identity that continually expands. And come on, let's face it, I probably could do to go back to podiatry school and start to learn all over again, because the stuff these guys are learning these days is like, it's not the spots off stuff I know and anything I did. And maybe then in another 5 years' time it's even different again, but we don't want a name to define that's the limit of what they can do. Is that answering the question?
There's no right or wrong answer, that's the thing. It's the answer from you. Okay, a couple of fun questions for you. It is your last day on earth. And
is that actually a statement?
No. Right, okay. If it was your last day on earth. That sounded like a threat, didn't it? By the way, it's your last day on earth. I wouldn't be at a conference. Well, I hope it's not your last day on earth. That'd be really annoying.
Yeah.
Well, it'd be more than annoying. Annoying doesn't even cover it. It'd be devastating. So it's your last. If it was your last day on earth, what would be the meal you would have? What would be the film you would watch?
Oh, that's not fair. The meal.
And it can include alcohol as well.
What would be the meal I would have? It would be a meal shared with people that are important to me, which would include friends and especially family. That on that last day I shared it with everybody who being gracious and good and an important part of my life, and it will always be my family, but I would like to incorporate friends of that as well, and it would be over a shared platter of food where we're diving in together and just sharing that out. It would be that fun kind of meal with a lot of fun and a lot of laughter, and I would actually push the boat out and have a Bolero, a bottle of wine or two. Right? You know, I'd actually go beyond the Malbec, and have a Bolero, a bottle of wine or two, and you know, some kind of cocktails as well, because some of my friends are cocktail freaks. So.
Yeah.
There's that one.
Okay.
What was the other part?
What with the film you'd watch? So after you've had this meal with all these people, you sat down and watched a film. What film would it be?
This is at this moment in time, because if it was my last day tomorrow, then I might have a different film. Midnight in Paris.
Okay.
Because it's the idea that I could go back to the 1920s. Well, firstly, that I could dance anyway, and actually dance in the 1920s. But I could go back in time to when you had the Renaissance art people, you know, all gathering round, chin wagging in the bar, in the pub as they're working things through. And just jump in this car and it takes you back to 1920s, it takes you back to the 1800s. I loved that idea of the fun of being able to dip in and out of history, the bits that you want to look at. And it was like, it was comic gentle, it was probably a bit of a twee film. It just did it for me at that point. And you know, if it's my last time on earth, why do I want anything serious? You know, let's have something that's a little bit fun and a bit fantasy and a bit whatever.
Awesome. So, you've got courses coming up this year, your fascia courses. Where can people find out more about that?
Website, www.infigoeducation.co.uk. You'll find the details on the ankle mobes and the foot mobes and the fascia courses. Currently awaiting COP approval. It looks encouraging for that, and they will run anyway because you know I do courses that aren't COP approved for my own benefit, and you put them on, you just to sort out your insurance, but if it gets that approval, it covers the insurance side for podiatrists anyway, and gives them that extended scope of tick. And that would be good because it means podiatry can then own something of that work. So the website, that will give you all the details. There's 2 level 1 courses and a level 2 course. Level 2 for those who did the pilot course this year, to go on and do that. So if you've not done level 1, you can't do that one. Ironically, level 1 is now almost full. Partly because those who came and did level 1 have put their putting their staff through.
Yeah.
They want their staff now to learn it because they found the benefits. And we had people ranging from those who do the regular foot care that we all do, with some MSK interest, to those who would be pretty well purely MSK, through to pod surgeons. We're all part of that group, and the feedback has been extremely positive. And you know, some of those are the people who are pushing their staff through. The great thing is, if we get it right, maybe we can start to do some contributory, really good research into it to feed it back into that evolving thing. You know.
You're going to become a researcher after all, aren't you?
Me? No. No. I wish.
It is always a pleasure talking to you.
Thank you.
And I take every opportunity I can to sit down and talk to you. And actually, we try to do this very similar when we're on the fascia course. I'm just hoping the audio's work now. If it hasn't, we'll have to do it again sometime. But we'll have to do it over wine. No, I really appreciate your time. Thank you very, very much, mate. You are an absolute gent. Thank you very much.
Thank you.